Clinical cardiac electrophysiology explains how cardiac electrical activity governs rhythm, conduction, and arrhythmias through cellular ion currents and organized propagation pathways. The modern era began with Einthoven's surface ECG over 100 years ago, and linking electrical signals to mechanical cardiac function and arrhythmias. Later discoveries of cellular membrane currents revealed that the ECG represents the summed electrical activity of millions of cardiac myocytes. The cardiac action potential drives all electrical behavior in the heart and maps directly to ECG phases such as QRS, synth segment, and T wave. Phase 0 corresponds to rapid sodium influx causing depolarization, and the QRS complex on the ECG. Phase 2 plateau is mediated by calcium influx through L-type channels and corresponds to the ST segment. Phase 3 repolarization occurs via potassium efflux and generates the T wave on the ECG. Ion channels regulate cardiac excitability through voltage-gated sodium, calcium, and potassium currents that shape each phase of the action potential. Pacemaker activity in the sinoatrial node is driven by the funny current and slow calcium-mediated depolarization in phase 4. Gap junctions composed of connexins allow rapid cell-to-cell conduction, ensuring synchronized myocardial activation. Impulse generation starts in the SA node, spreads through atria, and reaches the AV node where conduction slows to allow ventricular filling. The His-Purkinje system rapidly distributes impulses through bundle branches and Purkinje fibers to ensure coordinated ventricular contraction. Autonomic tone modulates conduction, with sympathetic stimulation increasing heart rate and vagal tone slowing AV nodal conduction. Arrhythmias arise from abnormalities in impulse formation or propagation, including automaticity, triggered activity, and reentry mechanisms. Enhanced automaticity results from spontaneous phase 4 depolarization in ectopic foci such as atrial tachycardia or idiopathic ventricular tachycardia. Triggered activity includes early afterdepolarizations causing torsades de pointe and delayed afterdepolarizations seen in digitalis toxicity. Reentry occurs when a circulating impulse persists due to unidirectional block and slow conduction in a closed electrical circuit. Reentry requires an excitable gap where tissue has recovered, allowing sustained tachyarrhythmias like AVNRT and atrial flutter. Structural heart disease such as ischemia creates fibrosis and slow conduction zones that predispose to reentrant ventricular tachycardia. Electrophysiology studies allow invasive mapping of arrhythmia mechanisms and are now commonly combined with catheter ablation therapy. Catheter ablation targets arrhythmogenic foci or reentry circuits using radiofrequency or cryothermal energy to eliminate abnormal conduction. Pharmacologic therapy includes sodium, beta, calcium, and potassium channel blockers that modify conduction, refractoriness, and excitability. Class 1 drugs block sodium channels. Class 2 are beta blockers. Class 3 prolong repolarization, and Class 4 block calcium channels. Pacemakers treat bradyarrhythmias by providing artificial electrical stimulation when intrinsic conduction fails. Implantable cardioverter defibrillators prevent sudden cardiac death by detecting and terminating malignant ventricular arrhythmias. Successful arrhythmia management depends on correlating symptoms with rhythm, identifying structural disease, and selecting targeted therapy. Key takeaway is that cardiac electrophysiology integrates cellular ion channel behavior with clinical rhythm disorders, enabling precise diagnosis and curative therapies.